Well, hello to you, our listeners, the manipulated and the manipulators. Welcome to the OMM Research Podcast. The OMM Research Podcast is produced by DO-Touch.NET, a practice-based research network that focuses on osteopathic manipulative medicine research. DO-Touch.NET is based out of the A.T. Still Research Institute, located at A.T. Still University in Kirksville, Missouri. Please note, as always, that the views and opinions of the panelists in this podcast are personal to each panelist and do not reflect the views or opinions of A.T. Still University. My name hasn't changed and is still Corey Lubring, and I am the Practice-Based Research Network Coordinator of DO-Touch.NET and the host of the OMM Research Podcast. And before we begin, we also just want to remind our listeners that this podcast recording has video recorded with it and can be viewed on the DO-Touch.NET YouTube channel. Our panelists for this episode are Dr. Stacey and Dr. Amendolara. So, as always, Dr. Stacey, would you like to introduce yourself?
I'd be happy to. I also have not changed my name. I am Dr. Stephen K. Stacey, DO, Director of Osteopathic Education at the La Crosse Mayo Family Medicine Residency Program. And while my name hasn't changed, the astute listeners may have noticed that between the first episodes and now, my academic rank has changed from assistant professor to associate professor. So a little Easter egg there, but now we're highlighting it out loud. And I'm also the course director for the Mayo Osteopathic Research and Education Conference this September 18th and 19th, 2026 in Minnesota.
And thank you for being with us again this month. And back with us again is Dr. Amendolara.
Hi, yeah, I don't have any good title changes. Unfortunately, my name is the same as always, but my name's Alfred Amendolara. I'm a neurology resident at St. Luke's University Health Network in Pennsylvania. I'm also an adjunct professor in our clinical research department at Norda College of Osteopathic Medicine.
Hey, there's one big, I'd say there's one big change that has come, and you are PGY2 now instead of PGY1.
In about a week.
I mean, by the time this comes out,
Yeah, by the time this
anybody
airs, yes,
listening to
I
it
will be officially a PGY2. Yeah.
Yeah, and you can get your license, sign your own controlled substances.
That's a big step. That's a big,
exciting.
It's exciting. Well, we're going to dive into our first article brought to us by Stephen, which is looking at mediation analysis.
That's right. This article is called Pain Self-Efficacy, Kinesiophobia, and Health-Related Quality of Life Mediate Pain and Disability Improvements with Goal Setting and Education in People with Chronic Low Back Pain, a mediation analysis of a randomized trial. Honestly, I didn't think they let journal titles get that big, but here we are. The authors are Walker et al. It was published in October 2025 in the Journal of Physiotherapy. From the abstract, their objective was how much do pain, self-efficacy, kinesiophobia, stress, and health-related quality of life mediate reductions in pain intensity and disability in people with chronic low back pain receiving a patient-led goal setting and pain science education intervention compared with general exercise advice. We'll unpackage that in a little bit, but their main findings are targeting pain self-efficacy, kinesiophobia, and health-related quality of life may drive important reductions in pain intensity and disability following a goal setting and educational intervention for people with chronic low back pain. I know that was a lot of mouthful, so we'll unpackage that a little bit here.
Sure. Well, but the first thing I want to unpackage for our listeners that may not know, could you give us a little explanation on what is mediation analysis?
This was a strategy that they used to figure out what was the causal factor behind the improvement that they saw in a previously published study. So the original randomized controlled trial showed clinically meaningful improvements in pain and disability from patient-led goal setting and pain science education. So what they did in that study is they randomized 75 adults with chronic nonspecific low back pain to one of two arms. One was the intervention arm, which was pain-led goal setting plus pain science education. So this was really an education intervention, not hands-on manual therapy, but we will definitely tie it back to OMM, I promise. The control was just standardized advice to exercise, sort of a typical like, hey, get out there and do stuff kind of advice. And
Hmm.
what they found was improvement the in the intervention group. And this study now is an effort to statistically see what are the mechanisms behind the improvement.
Interesting. So what about this article? What made you want to bring it to this episode for us this month?
I found that when we're doing manipulative medicine, a lot of the manipulation that we do is psychological manipulation as much as it is manual manipulation. And as we are helping our patients, a lot of the things that we do center around these ideas, these four things that they highlight: pain self-efficacy, kinesiophobia, stress, and health-related quality of life. So pain self-efficacy is the idea that patients can be in charge of their pain journey and find improvement through things that they are able to decide to do. And it's already been shown in multiple prior research studies that patients with low pain self-efficacy suffer worse pain outcomes. So their beliefs about what they're able to do with their pain actually drive outcomes. And so what they were seeing is whether that would apply in this case as well. Kinesiophobia, similarly, is this idea that movement is harmful, therefore I don't want to move. And when I don't move, I get more stiff. And then when I get more stiff, I get more painful. So then I don't want to move. So this concept of not really wanting to move is kinesiophobia. And stress and health related quality of life, I think, are two a little bit more intuitive terms.
Interesting. Dr. Mendelara, is there anything you want to add to that?
Not particularly. This is an interesting study. I like the statistical analysis they did with it. It's always interesting. This isn't something that I've done before, but my understanding of it, it's essentially asking the question. The initial study kind of, in a way, asked, how do we get from A to C, or is there an effect on A to C? What this study is looking for is, what is that B term in between the two? That is, I mean, as the title implies, mediating the effect. And I think that's kind of a useful analysis to do. As Dr. Stacey was saying, there's a lot of additional factors that go into manual therapy. It's not always a one-to-one. You do something physical and there's a physical outcome to it. There's a psychological component. There's other variables. And I think in general, this kind of secondary analysis, which is kind of, it's an analysis of an already published study, is really useful for filling out the entire causal relationship between a treatment and an effect that we're hypothesizing it's caused.
And we sort of understand this intuitively because nobody thinks that just going and getting education directly causes pain to get better. There's got to be
Right.
something that's happening to trigger that. And this is really hypothesis based, saying we would suspect that improvement in these other things would then mediate the improvement in pain. So that
Exactly.
pain self efficacy, kinesiophobia, stress, and health related quality of life would cause would be mediating that improvement. So that's a real strength of this study, is it's digging deeper into an existing data set. Of course, the weakness is you have to have really considered a potential mediating variable for
Right
it to be
at the start.
manifest.
Yeah.
And so this doesn't explore things that they didn't
Well,
think about.
hidden variables, right? It doesn't really explore hidden confounders.
Well, we have to be careful, educating people more, because if you talk to anybody's kids, just education in general causes more pain. So that
Yeah.
could be
Our
adding to more to this.
I will say our kids are at the age of education where we, as parents, are at peak stupidity.
Mhm.
They know so much more than we do. about everything. Just ask them, they'll tell you.
Absolutely. So what more is this study like? You all are talking about, like, how education is really benefiting these people with their ability to, I don't know, better understand their pain and being able to mitigate it or address it and such. And so what can we take,
Yeah.
how is this can be taken into a clinical setting, these results, for people to be able to better improve their quality of care that they're giving their patients?
Yeah. So the intervention didn't work by changing tissue the way that manual therapy might. And so we can add manual therapy to a lot of these educational type interventions by addressing things like confidence, fear, stress, and quality of life.
Mm.
What they ended up figuring out of all of these is they were looking at all of these. The pain self efficacy appeared to be the strongest mediator of disability improvement, and kinesiophobia was the strongest mediator of pain improvement. But those two, by and large, stuck out. The pain self-efficacy and the kinesiophobia stood out as better markers of pain improvement than reductions in stress or improvements in pain-related quality of life. And so as we are making interventions with our hands, we can also make interventions with our minds to help people feel more pain self-efficacy. And I make this part of my personal practice to always give patients something that they can do for their own pain. I tell them my goal is to make myself irrelevant so that they are in charge of their own pain journey by having strategies for dealing with flares when they come up or improving themselves through stretching, strengthening, things like that. But then also the kinesiophobia piece. One of the things that I love about osteopathic manipulation is that we couch our treatment in terms of improved movement, which really helps with patients feeling like they can move. What I'm doing is helping you move. Now you keep moving and you're going to keep doing better. Contrasting that with other models of manual therapy, which focus on um, things like subluxations or things where you're out of alignment, out of place. And if something's out of place and then you put it back like a Lego set, what's the way to keep it there? It's to not move it. And that
Mhm.
contributes to kinesiophobia, which is actually
Hmm.
counterproductive. And I know that other practitioners aren't meaning to do that, but I have had patients feel like they can't use their back once it's, quote, put back in place by other providers. And I really try to avoid that language. So if you take nothing else out of this, I would say focus on using your manual therapy to improve the patient's sense of their own self-efficacy and to reduce their fear of movement.
Good takeaways. And Al, if you were
Yeah.
to take this study to a next step, where would you take the study from here? Like, what would you see as the next step of this type of research?
I mean, I think this study does a really good job about of giving us a usable clinical outcome. I think the idea that based on this research, based on the prior study, we can say, well, we know that pain self-efficacy, we know that kinesiophobia are mediators in this sort of these intermediate steps in helping their intervention be more effective. It lets us in a clinical setting it's pretty low risk to keep those in mind as we're providing patient education, as we're providing treatments. So I think you can take that and run with that in a clinical setting. In terms of next steps for research, this is um, the type of study that I think can be repeated with other primary literature. This is the type of secondary analysis that if you've done a study where there's a high chance that there are mediators, especially if hopefully you've tried to address those or you were aware of them at the onset, this can give us more usable clinical information, which I think sometimes is lacking from osteopathic trials. We jump a lot from point A to like point Z sometimes, and we're missing a lot of steps in between. And this is really exactly one of the ways that you can start to fill in those the rest of the alphabet in between, essentially.
That's a
Gotcha.
really good point. And they had to think about these things
Right.
from the get-go. So you can tell this was a planned secondary analysis from the
Hmm.
beginning because they got information about these secondary endpoints from questionnaires that have been used in other validity studies or are widely used by the field to measure things. So they didn't just go straight from here's our intervention to here's our outcome. They gathered a
Hmm.
lot of data along the way so that they could have this. And they didn't pick these at random. They really did a good literature search and were very well aware of the kinds of mediators that have been shown in prior research. So this really builds on a foundation of a hypothesis that is already well on its way in the manual therapy research. So they're not just coming up with this willy-nilly, but finding the the evidence to support or refute existing hypotheses and models.
Awesome. Well, thank you for bringing this article to us this month. It's exciting to dive into. And before we dive into our next article, we do just want to remind our listeners that if you want to see our beautifully bearded, mustached faces, that you can find us on the DO-Touch.NET
Sorry, I
YouTube
betrayed
channel.
you guys.
That's all right. The facial hair still exists in some form. But
Yeah,
it's
I grew
DO.
taller than the rest of my hair, so the top of my head is a little bit more barren.
But that's DO-Touch.NET. That's DO-TOUCH.NET. You can find us on the YouTube channel or check us out on our website, which is spelled the exact same way. And our next article is based on a topic that we come to in a lot of our previous episodes, but the article is now just focused directly on it, and it's looking at blinding and sham treatment. And I'll pass it over to Dr. Amendolara.
Yeah, so this article I thought was interesting. It's very relevant to things that we bring up probably a little bit too much on this podcast, but recurring themes. It's titled Meta Epidemiologic Review Blinding and Sham Treatment in Clinical Trial Design for Osteopathic Manipulative Treatment Research. It's by Irving et al. It was published in the Journal of Osteopathic Medicine in 2024.
The International Journal of
International, I'm
Osteopathy.
sorry, International Journal of Osteopathic Medicine. Um, uh, Briefly to summarize it, we won't get too much into the actual results of the study. I think their discussion is the more interesting part here. But they did a structured literature search and evaluated 83 blinded OMT randomized controlled trials published between 2009 and 2021. And they looked at a variety of different factors. They looked at sham categories, they looked at blinding, they looked at assessment of blinding, effectiveness of the blinding, and all these kinds of different things. And then they sort of discuss it and they give us their thoughts on it. And they had some interesting results. Um, in general, they found 5 big sham categories. Most of these trials used light touch. Some of these used unrelated sham treatments, meaning something like an ultrasound or a generic exercise. A percentage of these used incomplete maneuvers, so they set up the treatment but didn't actually do any of the therapeutic movements. And then there were a handful that did either no touch kind of sham controls or incorrect positioning, things of that nature. Um, they did find that about 80% of these trials at least attempted to blind their subjects. About 70% attempted to blind the data collectors, the evaluators, but only about 20% of the physicians delivering the actual treatments were blinded. And interestingly, only about 10% of these studies, out of the 83 studies, only about 10% actually assessed whether their blinding was effective. Um, so that's kind of their general findings on it. But this study to me really touched on all of the things that we bring up sort of over and over again when we're discussing the trials that we bring onto this podcast to sort of sometimes complain about, but to review.
So to open
Yeah,
the
this.
proverbial can of worms. Oh, sorry. Go ahead, Dr. Stacey.
Oh, I just think that this is great because it highlights, you're right, a lot of the things about what we would like to see in more manual therapies research studies. So we talk a lot about, increasing the N number, and that's great.
Hmm.
And people always say, though, it's so hard to do manual therapies research because you can't do a placebo. And that's true in the strictest sense that, a placebo sugar pill, yeah, doesn't really work. But there are
Right.
lots of interventional studies outside of manual therapy that use ways of analyzing it. And it's bringing a lot of those best practices into that. And one of those best practices is looking at your alternatives and saying, what is the evidence behind their ability to maintain an appropriate control? This is really cool.
Yeah. So what about that discussion? What about this? Did you want to discuss here related to sham treatments?
There's so much to discuss. I think they bring up a couple good points though. The first is a general point that the way we talk about single blind, double blind, triple blind studies is not particularly standardized. Something that I thought was interesting was a number of the studies that claimed to be single blinded actually had sort of variations in who they were actually blinding, which I think as a reader is very relevant. So about 43 studies claim to be self-blinded. 16 blinded the subjects, 18 blinded the evaluators, and 10 blinded both the subjects and the evaluators, which is really probably a double blind design. So just as an example, there's a lot of sort of inconsistency with how we're labeling these studies, which I think is something we usually talk about this more when it comes to calling something a pilot study or things like that. We complain that it's not very standardized, but I think it's relevant to know that when you read the title of a study or what the authors are claiming, you know that who they blinded and who they didn't blind and how that might manifest in bias or how it could change the results and conclusions.
And
Um,
how blinding was performed and how
right,
successful it was. One of the
which is the
things that I,
major.
yeah,
Yeah,
they pointed this out even right in the abstract.
yeah,
They said the use of questionnaires to determine the success of blinding should be considered. I think, if anything, that's maybe too lightly
right.
phrased.
I think they should be mandatory. Really,
Right.
I think absolutely. I also think there's something interesting that they acknowledge that there's difficulty in blinding the physicians who are performing OMT for hopefully for obvious reasons, but they also note that that doesn't mean that we should chuck that idea out the window. And they also, I think they make a really good point that there's a difference between blinding the evaluators or the people collecting the data and the person delivering the treatment. So you might say, well, we double blinded it because we blinded the participants and the people collecting the data, but that's really controlling for different biases than if you blinded the participants and the person providing the treatment. It doesn't mean it's wrong or the incorrect way, but it fundamentally you're controlling for different factors. And I think that's kind of relevant. We see a lot of studies that call themselves double blinded, but really what they're doing is blinding the participants and the evaluator, not necessarily the osteopathic physician or whatever practitioner is delivering the treatment. Um,
Which, you're right, that's not always going to be possible, and
right.
probably most of the time it's not going to be possible. But what you should definitely have a separation between is anybody who knows what treatment allocation is and anybody who is gathering data or
Right.
processing data for the study. So whoever is making the primary outcome assessment really needs to be blinded. And in a lot of cases, that's the patient themselves from
Hmm.
like a self-reported questionnaire, and that's where we get back to this idea of knowing, was the patient in fact blinded, or
Right.
or did they have evidence of unmasking such that they were very aware of treatment allocation?
There's also another point that they make that is again I'm going to say we say these all the time, but the difficulty in choosing a sham because we know there is an effect. There is a placebo effect, there is an effect of light touch, there's a therapeutic effect to touch on its own, which is been documented in the literature. And it really calls into question just having two arms in these kinds of trials. I know there's big logistical issues, but they make a really good point that when it's possible, probably having three arms in your trial is really beneficial to separate positive effects from your treatment from just psychological effects or effects of light touch, therapeutic effects that are different from your intervention, but then also which may be separate from a complete no intervention type control or a different unrelated treatment type thing. That was interesting
I
to me.
would
That's something that I would like to see more of.
I would even argue that for some of the types of studies that have been done much more than others, like manual therapy and low back pain has been done
Hmm.
a lot. We know that manual therapy can help in low back
Yeah.
pain. So we have some unsettled questions there that really need to be part of any future investigations. Things like
Hmm.
how much training does the practitioner need to deliver successful treatment? Could you have somebody that took a 20-minute crash course that does as well as somebody who's been doing it for a whole career? Do you find differences there? Or other things like looking at these mediating factor analyses
Hmm.
or comparing physician directed OMT versus protocol directed OMT and seeing in particular cases, does it make a difference? These are the kinds of open questions that we have. It's not really an open question anymore, though. Does manual therapy help in low back pain? We know it does. So let's start asking uh,
Right.
more more informative questions. Other things, we may not be there yet. Like, do we know how well OMM really helps with things like chronic abdominal pain? I would say less so than with low back pain. But even as you're starting studies that are perhaps a little bit more exploratory, this last study that I did and the one that you're doing now show the value of just gathering extra data along the way so
Hmm.
that you can explore hypotheses underlying potential mechanisms.
Hmm. Well, this question that I've kind of been thinking about as you've been discussing this, I want to posit towards both of you. Instead of really asking where would you take this research in the future, more so related to blinding and sham treatment and the past conversations that we've had in it. What would be the recommendations or practices that you would strongly recommend to those doing osteopathic research that would be able to bring the validity of the results to the next level as it relates to blinding and sham treatment? What would you like to see done as best practices?
You, you know, it's funny you should ask that because that is their entire conclusion. They give us some excellent recommendations that I don't want to pretend that I came up with these on my own because I think they do a great job of listing them out. They have four big recommendations. Um, they recommend ensuring double blinding actually entails blinding the subjects and the evaluating clinicians. Um, and additionally, any other data collectors. And then their second recommendation is that you have someone independently providing the treatment. So an osteopathic physician who is performing treatments, but who really has no engagement in the actual data collection or analysis. So you circumvent having to blind your treatment provider by having them, as Dr. Stacey, I think you already mentioned this, having them separate from the data, the collection and analysis stages of the study. They also mentioned their third recommendation is that post-study analysis to determine the success of blinding should be an integral part of the trial design. I think we harp on this a lot,
Mm-hmm.
and that is an easy recommendation. And then they also recommend the general awareness of the fact that significant outcomes arising from sham techniques necessitates their deliberate incorporation into study design. Essentially, again, something that we've been saying that where it's possible, the inclusion of a no treatment control arm, essentially a third control arm, or at least the awareness of your choice of sham treatment can have a large impact on your outcomes and your eventual conclusions.
And you
So
stand
those
by
are the
those recommend?
recommendations I would
Yeah, you would stand by
absolutely.
those.
Yeah, absolutely.
Yeah, I would stand by those too. And in answer to your question, where do we go from here? This is a big pie in the sky dream of mine, but I would love to have a society supported, internationally led process of finding of creating reporting guidelines for manual therapies research that would
Yeah.
incorporate all of these things, because we have, a lot of other disciplines have reporting guidelines. We have reporting guidelines for every different kind of uh, survey, study, every different kind um,
Reviews, clinical
yeah,
trials for
review.
most
Yep.
things. Yeah.
Uh, but we don't really have a good one for manual therapies research that the journals could go to and say, follow this guideline. And in that
Hmm.
guideline is something that says, report on how you did this, or report on the fact that you didn't do this as a weakness. And
Right.
and when authors look at that and they see, oh, to follow this guideline, I needed to have done this, that's really going to shape how trials get run.
No, that's a great point. Yeah.
Yeah, I
Well,
couldn't agree with that more.
So if anybody out there listening to this wants to do that, wants to spearhead it, please get in contact with me. I would just be tickled pink to get this lifted off the ground.
awesome. Well, thanks for this awesome article this month, Dr. Amendolara. It's a great conversation related to it. And before we go, we want to, of course, thank our panelists this month. Remind you all that if you want to find out more about what's happening within DO-Touch.NET, you can always go to do-touch.net to see what's happening within our network. And I believe, Dr. Stacey, this might be the last time for you to plug the conference that's happening up at the Mayo Clinic.
That's right, the Mayo Osteopathic Research and Education Conference, or MORE, in Rochester, Minnesota. Come join us from September 18th to 19th, 2026.
Oh, yeah.
Bring your research that you're doing.
We'll have one more episode that we can still plug it. But yes,
Yeah.
absolutely, you all should go if you can, because
And there's also going to be a residency fair. So if you're affiliated with a residency, uh, find our website. You can just Google more Mayo osteopathic, and it should show up. You'll see how to do that there. If you're a medical student, please come. It's going to be on Friday, September 18th.
And if you haven't yet, smash that follow and subscribe button. Follow along with this amazing, awesome podcast as we continue to dive into osteopathic research. And Dr. Stacey, Dr. Amendolara, thanks to you both again for being with us this month.
Always
Ciao.
a pleasure.
Yeah, and we will talk to you all next time.